Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent medical educational grant from Regeneron Pharmaceuticals, Inc. and Sanofi.
Hi, I'm Dr. Mario Castro. I'm the Lee Phillips and Lenore Carr Phillips Professor of Medicine at the University of Kansas School of Medicine in Kansas City, Kansas, Chief of our Pulmonary and Critical Care and Sleep Medicine group here. I want to welcome you to this program on Beyond the Inhaled Corticosteroid Plateau, Targeted Strategies for Moderate to Severe Asthma. So as we've evolved in our understanding of asthma, we've now realized that it's really quite heterogeneous process. All asthma is not the same. We know that all asthma does include an inflammatory process, and as a result of that inflammatory process, there's remodeling of the tracheobronchial tree, and this includes the small airways. And we know that over time, this leads to progressive loss of lung function. What we're going to examine today is looking at that interaction between airway inflammation, the resulting remodeling that occurs with that, as well as the airway hyperresponsiveness, really those key tenets of the underlying pathophysiology of asthma. So I'm going to be talking about the role of type 2 inflammation and how it contributes to that pathophysiology. We're going to cover some of the current asthma treatments and how they may or may not be effective for remodeling of the airways. We're going to look at some of the new biologics and how they potentially target this airway remodeling, how we're looking at that, how we're measuring that, and how that we can do that clinically. And we're going to talk about some new concepts, this concept about mucus plugs. What do they mean? And we're going to talk about how potentially we can use some of the newer therapies to potentially reverse that part of the pathophysiology. And what does that mean for our patients? So first, in kind of background in terms of thinking about asthma, we know that in general, there's type 2 inflammation. And then at this point, we know that there are other types of inflammation in asthma. We kind of lump those into that non-T2 inflammatory process. So when we think about type 2 inflammation, what do we think about? We think about an allergic component. We think about inflammation in the airways that is associated with eosinophils and T cells in the airway. And this type of inflammation is very responsive to corticosteroids. Now let's go to the other end of the spectrum in that non-T2 disease, and that's predominantly associated with neutrophils in the airway and less responsiveness to corticosteroids. And of course, there's overlap between those two extremes of the pathophysiology, in that in both conditions we see remodeling changes as demonstrated by increase in the smooth muscle size and number, by increase in thickening of the basement membrane of that subepithelial fibrosis that occurs, and loss of that epithelial integrity associated with goblet cell metaplasia and mucus hypersecretion. These processes lead to kind of the underlying pathophysiology of asthma, which is characterized again by that reversible or less reversible airflow obstruction, airway hyperresponsiveness, and the underlying characteristics of that inflammatory disease in the airways with asthma that leads to the remodeling process. So let's dive a little deeper into this with the following animation. Asthma is a complex chronic inflammatory disease with lasting structural changes. We know that behind the scenes, chronic inflammation drives airway remodeling in asthma. What we've seen at the cellular level is that there are changes in the cells in both the large and small airways, as well as the surrounding extracellular matrix. These changes include epithelial dysfunction, smooth muscle hyperplasia and hypertrophy, and goblet cell hyperplasia. Now let's briefly review some of those changes and the role that they play. First, epithelial injury results from chronic inflammation and modification of the proteins that are involved in proliferation, apoptosis, and migration of those epithelial cells. Over time, this ongoing damage disrupts the normal repair mechanisms and drives the airway remodeling that we see in asthma. Now, airway smooth muscle cells also undergo changes, including hypertrophy and hyperplasia. This leads to thickening of the walls of the airways, as well as changes in smooth muscle contractility. This clinically contributes to the airway hyperresponsiveness and airflow obstruction that is seen in our patients. Next, a key process is changes in these unique cells called goblet cells that line the airway. They undergo hyperplasia. They are loaded with these mucin proteins. And below the epithelial layers, this submucosal gland that undergoes hypertrophy and leading to that excess mucus production. This results in narrowing of the airway lumen and an increased wall thickness. And because of that, the mucus that is in that lumen then leads to mucus plug formation. Now, collectively, these structural disruptions fuel the bronchial hyperresponsiveness that we see clinically in our patients and the airflow obstruction. Over time, this drives decline in lung function that is characteristic of this chronic disease process. These processes also hit the smallest airways. These airways are reflected by the narrow bronchioles with thickened walls. These narrow airways and the small airways then lead to greater airway resistance and less airflow. And this is what we refer to as small airways disease. Now, a key culprit in this airway inflammatory response and this remodeling response is type 2 inflammation. We know that this is driven by the classic type 2 cytokines, IL-4, 5, and 13. Now, upstream of that, there are these epithelial cytokines, or what's referred to as alarmins, including TSLP, IL-33, and IL-25. Now, they trigger and amplify their production by Th2 cells and ILC2 cells. This also drives eosinophilic recruitment, mucus overproduction, and tissue remodeling that lead to the classic pathophysiologic changes we see in asthma. Now, these epithelial cytokines, or alarmins, are released by the epithelium in response to a variety of different insults, such as environmental injury or immunologic insults from allergens, pollutants, smoke, or even respiratory viruses. Once released, these epithelial cytokines, or alarmins, drive downstream type 2 and non-type 2 inflammation, and they initiate the structural changes that we see in that airway wall, which we call remodeling of the airways. Now, one of the key alarmins that we mentioned is TSLP. And we know that it plays a role in the production of extracellular matrix components by stimulating the underlying lung fibroblasts that are in that submucosal space. Together, the TSLP, these drive fibrotic changes in the subepithelial space. IL-33 and IL-25, again, are two of those other alarmins. They also play a role in increasing collagen and lung fibroblast proliferation. Now, in asthma, this ongoing alarmin release, these epithelial cytokines, maintain the inflammatory response by generating chemokines and cytokines that recruit additional inflammatory cells, such as the eosinophils, neutrophils, and other innate immune cells. Now, downstream from these alarmins are the type 2 cytokines that drive the pathologic airway remodeling processes in our patients with severe asthma. Let's review some of these key pathophysiological responses. First, in that classic allergen response, in the early phase, IgE binds to the receptor on mast cells and basophils. This then triggers the release of histamine, leukotrienes, tryptase, and prostaglandins from those mast cells to basophils. And then these cause vasodilation, edema, and bronchoconstriction. In addition, IgE binds to the B cell receptors and enhances antigen presentation, leading to the subsequent cytokine secretion and recruitment of pro-inflammatory cells such as eosinophils and basophils to the inflammatory site, and promoting overexpression of mucus-producing goblet cells that contributes to that airway hyperresponsiveness. Secondly, IL-5 is a key cytokine that drives the development of eosinophils. We know that IL-5 not only does that, but also sustains their survival in the airway and directs their migration to the airways, therefore, classifying it as a chemokine. Now, these infiltrating eosinophils play a role in directly remodeling the small airways, depositing extracellular matrix, driving smooth muscle hyperplasia, and altering the epithelium, which disrupts the epithelial barrier, those tight junctions in the epithelium, and it results in stiffer walls, reduced airway compliance, and increased in airway resistance. Next, IL-13 has multiple remodeling inflammatory processes that it triggers in the airways. It promotes smooth muscle proliferation, goblet cell hyperplasia, and mucus hypersecretion, as well as stimulating fibroblast-mediated extracellular matrix deposition and leading to that subepithelial basement membrane thinning. Lastly, one of the T2 cytokines is IL-4, which promotes activation of mast cells, differentiation of these T cells into those T helper cells, and then IgE class switching in B cells. All right, as just demonstrated here, we've talked about the various components of that inflammatory response. And we're now going to start talking into what are the therapies that one would use in our patients. What are the patient, how are our patients responding to those therapies? And what we've learned with most recent studies in terms of how do we approach this perhaps a little bit differently as we think about asthma, again, being very heterogeneous. Not everybody's in that same bucket. And we have to really be creative in thinking about how do we understand what's the driver of that inflammatory process, and then how can we target our therapy towards them. Now, the cornerstone of asthma management really has been with inhaled corticosteroids. We know that inhaled corticosteroids are effective in reducing asthma symptoms, improving their asthma control, and leading to reduction in exacerbations, hospitalizations, and even mortality. We also know that these inhaled steroids are safe to use in our patients via the inhaled route. Where we get into problems, obviously, is when our patients are exposed to oral steroids and systemic effects from oral steroids. There have been several studies that have shown that inhaled steroids do have a small impact on airway remodeling in terms of reducing that inflammatory component, reducing the thickness of that wall of the airways. But there's quite a bit of variability in terms of understanding, does it really have kind of key aspects of reversing some of the other components of the remodeling process, like goblet cell metaplasia, smooth muscle hyperplasia, all these things at this point, there's less evidence behind that. And we know that ICS just may not be sufficient, just not enough to really control, to manage that disease process in our patients. We know that some patients, again, our thinking has really changed about the inhaled steroid dose that we used to. We used to step up our therapy to high dose inhaled corticosteroids and would leave patients on that. That's really not the current paradigm of treatment for our patients. What we'd like to do is really think about patients needing some type of inhaled corticosteroid dose, optimally low to medium dose inhaled corticosteroid. If we're going to try high dose inhaled steroids, we increase that dose of the steroids, look at the response, and if there's not a clinical response and some other marker of response like lung function or airway inflammation, then we go back down on that dose. So key understanding is that inhaled steroids are effective for asthma management. but they're not necessarily there for long-term high-dose therapy like we used to do in the past. We need to de-escalate that therapy. I want to think about, some patients I've, seen recently in my clinic, and I still see patients that are, being referred to me from their local physician on really high doses of inhaled steroids, 1,000 micrograms of fluticasone a day or even more. Sometimes left on 10 milligrams of prednisone. I had a patient the other day for the last 2 years, and this was, after a serious attack, but then their disease was pretty stable, and there was really not that attempt to de-escalate. So again, what we've learned now is that long-term steroid exposure has cumulative effects. Those cumulative side effects impact our patients' quality of life long term. When you're starting to see the weight gain, you're starting to see the development of diabetes, and a lot of these complications we see from steroids. So the driver right now is to minimize that dose of steroids. So let me pause here and ask, how many of your patients with moderate to severe asthma remain uncontrolled despite being on high dose ICS? All right. And as we talk about inhaled corticosteroids, there's one aspect that we're going to focus a little bit more on, which is how do those steroids get to those small airways? And so we know that type 2 inflammation is a systemic problem. We now know that it's not just affecting the large proximal airways, but it's also affecting those small airways. And we know that steroids sometimes really do not have adequate delivery to those distal small airways. We know that that remodeling process may not be altered by inhaled steroids, right? Because we now know that lung function decline is really not altered by that. We know that there are some patients where that anti-inflammatory with inhaled steroids doesn't address some components, such as, the goblet cell metaplasia, the mucus overproduction from them, the smooth muscle remodeling. All those things, unfortunately, are not addressed by inhaled corticosteroids. And therefore, we have this underlying pathophysiology that may occur in a subset of patients, even despite being on moderate or high doses of inhaled steroids. So we really need to think about kind of what are the newer treatments that we have, the biologics. Obviously, some of the biologics like anti-Ig therapy have been around for a number of years, but certainly in the last 5 to 6 years, we've seen a lot more of these biologics develop. And, when we think about how they have been utilized to date, one of the things that we have really learned is that, yes, they do control the disease when you select the appropriate subset of patients to treat. We do know that if you select the right patient and you get a clinical response, that is great in terms of controlling their symptoms, improving their lung function, and eliminating exposure to corticosteroids and really having no exacerbations. So those are the goals of therapy. I talk with my patients. I review that at each of our office visits. But now what we're delving into is a very exciting area, which is really how do we think about long-term remodeling? How do we think about changing that part of the disease process so our patients, as they get age and get older, don't have limitations from their fixed airflow obstruction? So I want to briefly talk about some studies. First one is one that we published recently in the last few months called Vestige. And in this study, we enrolled patients that were 18 to 70 years of age with type 2 asthma. We then randomized them to dupilumab, anti-IL-4 receptor, at 300 milligrams every 2 weeks versus placebo. And in this study, the co-primary endpoint was reduction in inflammation, reflected by FeNO of less than 25 parts per billion, but also change in airway remodeling as measured by our CT scan using functional respiratory imaging. So what we found in Vestige was that, yes, patients' airway inflammation is controlled with dupilumab, and that about 2/3 of patients had a exhaled nitric oxide level less than 25 parts per billion. Keep in mind, these patients were already high T2. Their FeNO at baseline was 50 to 60 parts per billion. The second part was trying to change that remodeling. In this, we looked at what's called SI vol. What that represents is the airway volume across the entire tracheobronchial tree. And so this is a great potential measure of airway remodeling, because we know as remodeling occurs, you get encroachment of that airway lumen. And what we found in this study was that there was a 20% improvement in airway volume into the airways with dupilumab in comparison to placebo. However, there was a lot of noise around that measure, and so did not quite reach statistical significance. However, another kind of secondary finding was what was happening to what's called the mucus plugs that were in the airway. And what we found in this group of patients with high T2 inflammation, about 50 to 60% of them had significant mucus plugging. And so when we quantified this with using a scoring system that we had applied in the severe asthma research program, we found that we were able to reduce that after 6 months of therapy. And this was highly significant in comparison to placebo. And so what we've now have evidence is that by reversing the mucus plugs, what does that mean? Well, what happens now is that their lung function significantly improves because you're improving airflow and airway volume to those distal airways. And of course, this is, translates to improved symptomatology and how our patients feel in response to that biologic therapy. When we think about other therapies, biologics, I want to go through a few examples of that. And first, in terms of anti-IL-5 therapy, we have mepolizumab. Mepolizumab, we know in this study by Kotsui and colleagues, is that it has an effect on dampening airway inflammation, but also has an effect on the small airways disease. And that's best reflected by impulse oscillometry, where you see an improvement in that R520, that resistance measurement that we get from impulse oscillometry, correlates to that distal small airways disease. And in this particular study of 130 participants with two comparisons group, after 6 months of treatment, there was a significant improvement in those measures of impulse oscillometry, which correlated nicely with other measures from lung function studies, as well as asthma control and asthma quality of life. So I think, what this has allowed us then to kind of think about in response to mepolizumab is that this therapy allows us to reduce the inhaled steroid exposure, and it allows us to really control that disease in terms of reducing their healthcare utilization and exacerbations. Now, we'll next move on to another study by Melissa McIntosh and colleagues, where we looked at the effect of another anti-IL-5. This is an anti-IL-5 receptor blocker, benralizumab. And in this study, again, they measured that mucus score that we were talking about, the number of mucus plugs that are in the airway. And that score, again, is from 0 to 20. And in this particular study with benralizumab, there was a significant improvement from baseline to the follow-up visits was in some patients up to about 2 to 2.5 years. And so we saw an average from about 3 mucus plugs going down to about 1 mucus plugs in the study with benralizumab. Next, another study with benralizumab, and this demonstrates that, again, when one looks at use of benralizumab in this kind of pre and post comparison, there was a significant reduction in that mucus score. And there was this correlated with improvements in airway volume as well as lung function. Now, I next like to move on to another biologic, which is anti-Ig therapy with omalizumab. Not a lot of controlled studies in this single study, a single center study by Shi and colleagues with 61 patients with refractory asthma. Again, showing by systematically measuring those mucus plugs that there was a significant reduction in those mucus plugs. And this, again, was suggestive that there was a benefit from omalizumab therapy on the mucus plugs, improvement in asthma controls, reduction in healthcare utilization. And this, again, correlated nicely with what we were seeing on the CT scans in terms of reducing those mucus plugs. Next, I'd like to talk about the latest anti-TSLP, or the latest anti-biologic, and this is tezepelumab. And in this study, again, they had a placebo control. They looked at patients treated with tezepelumab over a 6-month period of time in comparison to that placebo group. And what you'll notice there is that, there was substantial reduction in mucus plugs, so that with tezepelumab, we saw that there was a reduction from, about 1.5 to 2 mucus plugs on average with 6 months of treatment with tezepelumab. And this again correlated nicely with improvement in lung function in FEV1 as well as in improvement in FEF 25/75. So I think what we've learned now with these biologics is not only are they reducing exacerbations and helping our patients' quality of life improve, but we're actually now altering the disease process of airway remodeling in the proximal airways and also in those distal small airways disease. A lot of work still to be done in terms of understanding these studies, but I'm excited about it because as a pulmonologist, we've never talked about disease modification. We've never really talked about inducing remission. All my rheumatology colleagues can say that, and I think that's exciting for our rheumatoid arthritis patients. But now we're starting to think about how we can do that in asthma and airways disease. And I think that's ultimately our treatment goal, is that indeed we can achieve remission in some of our patients and achieve control. So in conclusion, I'd just like to mention that it's really an exciting time in how we are learning to use these biologics effectively in our patient population. How do we select the right patients for a biologic therapy? And now we can talk about disease modification and remission, which is exciting for some of our patients. And I'd like you to think about a change that you can make in your approach to uncontrolled asthma. After better understanding what we've talked about today in terms of airway remodeling, mucus plugging, and small airways disease in the role of T2 inflammation. So thank you very much for participating in this activity, and please continue on to answer the questions that follow and complete the evaluation. Thank you.